Are you able to see my presentation? Okay, great. All right, and so this one is really talking about some of the finer details of decision making with hepatitis C, where last week was a real general overview of treatment. So we'll talk about a lot of different things today, including identifying potential drug-drug interactions with hepatitis C direct-acting antiviral medications, talking about how important it is to treat both HIV and hepatitis C in co-infected patients, and then talking about some different options for special populations. Okay, so first I'm going to start with some drug interactions, and this is not going to be a comprehensive list, right? So make sure that you're checking all the medications, but I am going to talk about a few of the most common ones that we see when we are treating hepatitis C. So I kind of lumped these together by the different types of medications. And so this one is drug interactions that are common to medications that have an NS5B inhibitor in them. So these are the ones, at least for the most common ones today, have sofosbuvir in it. So you know it's the NS5B and the sofosbuvir. So they both have Bs. The brand name medications are Sovaldi, Harvoni, Epclusa, and Vosevi. So some of the more common drug interactions that we see involve the P-glycoprotein substrate. And so we really want to avoid ones that are inducers of this. And that includes all anticonvulsants except for Keppra. So if a patient is on seizure medications, right now the only option that for medication is Keppra with the hepatitis C medications that have sofosbuvir in them. Other things that we know are pretty common inducers of the PGP system are rifabutin, rifampin, and rifapentine. And then one thing to make sure to ask is about over-the-counter medications. And so St. John's wort is a very commonly used over-the-counter medication that patients will use for mood, depression, that type of thing, and they'll forget to talk about medications they're on over the counter. So it's something I always ask specifically is like, what medications do you get that are over the counter, not prescribed? And so St. John's wort has a lot of interactions in general, but definitely with hepatitis C medications. And so these are ones, we want to avoid. Then some of the HIV protease inhibitors, such as topranavir and ritonavir as well. Another thing to think about is that if a patient is on amiodarone, then the combination with the sofosbuvir can cause serious symptomatic bradycardia. Okay, sorry, it wasn't advancing. So now I kind of moved over to, so it's some of the same medications, but the interaction is with a different component of the medication. And so this one is with the NS5A inhibitors, specifically ledipasvir and velpatasvir. And so the NS5A inhibitors have that AS in it, right? ASVIR there. And this is specifically Harvoni, Epclusa, and Vosevi. And so you have some PGP and then some other different types of interactions here. So digoxin is one that you'd want to have more frequent monitoring if a patient is on digoxin and one of these medications. And then a really common one is rosuvastatin. And so these medications will increase the concentrations of rosuvastatin. And so the co-administration isn't recommended, but if a patient must be on the rosuvastatin, then no more than 10 milligrams a day when you're talking about using Vosevi. But it's not recommended with the soft Velvox, which is, I just said Vosevi wrong, okay. Don't use it with Vosevi or Harvoni, but if you need to use it with Epclusa, 10 milligrams a day is the max. Sorry, I misspoke there. But something you can do is change to the lowest dose of atorvastatin, and then you would be able to use Harvoni in that instance. Let's see, so glecaprevir, which is the protease inhibitor component of Vosevi, has higher drug interaction potential. And so here's some medications that are not recommended. I just highlighted a few of the more common ones that we might see, which is methotrexate and sulfasalazine. And then if patients are on statins, you're gonna, with any of these medications, honestly, if a patient is on a statin, then you may need to decrease the dose of the statin, or at the very least, monitor for signs and symptoms of statin toxicity. So muscle pain, dark urine, you might check a baseline CPK on these patients. And then if they come in having some myalgias, then you can check it again and see if that's from the statin potentially. So back to the NS5A inhibitors. So that ledipasvir and velpatasvir, they both require stomach acid in order to be absorbed appropriately or best. And so one thing that we like to limit is any acid reducing agents. So specifically proton pump inhibitors. And it was only studied with omeprazole, and it's only approved with doses of 20 milligrams or less daily for omeprazole equivalents. Now, I know with our hepatitis C echo and with the patients I see here at the healthcare center, we're a little more conservative than that. And honestly, we like to have patients off of all proton pump inhibitors if possible, just because in case they use more than prescribed, and just to give them their best shot of cure. And that's kind of what I tell the patient. It's like, hey, this is your chance. Let's see what we can do here. So with sofosbuvir ledipasvir, which is Harvoni, you would administer it simultaneously on an empty stomach if they were to take the 20 milligrams of omeprazole. With Epclusa and Vosevi, the recommendation is to take those medications with food 4 hours before the omeprazole. So hopefully that's creating a little bit more of an acidic environment. So when you eat, your stomach's going to release those acids to start the digestive process, and then later take that omeprazole. And hopefully then by the next day, your levels are a little bit lower is the idea behind that. There has been some talk about taking it with something acidic like orange juice or a Coke. And I don't think there's been a lot of studies that say like, hey, yeah, that's really going to make a difference. But you could make that recommendation in a patient who's on a proton pump inhibitor. One thing I like to do is consider discontinuation of acid suppression if they can. So I feel like there are a lot of patients who maybe were started on a proton pump inhibitor while they were in the hospital. They come back to clinic and maybe that was never discontinued. It just got sent home with them like on their to take list. And maybe they don't even need to be on it anymore. Or maybe they were supposed to be on it for a short like 14 days, but then it just never got discontinued. So I think there's a lot of room here, aside from hepatitis C treatment, to think about trying to get patients off of proton pump inhibitors or at least decrease the dose, because it's not like proton pump inhibitors don't have their own inherent risks. So if we do want to try to discontinue that therapy, then the recommendation is to reduce their PPI dose by 50% a week and then down to their lowest dose. And then that way you're going to have less chance for rebound hypersecretion, because if you just stop those PPIs, especially those higher dose ones, people are not going to like it and they're going to want to go back onto the PPI. So other acid reducers to think about are antacids, right? So Tums, Rolaids, and the recommendation there is to separate it by 4 hours from the hepatitis C medication. And then H2RAs, which right now just famotidine, I should scratch ranitidine on there, can be taken not more than 40 milligrams of famotidine twice daily. And so even less than that if they can use less. But the recommendation is to give it at the same time as the hepatitis C medication and then 12 hours apart. So if somebody is on a PPI, you can try to transition them over to an H2 blocker. Maybe even if they could take it 1 time a day instead of twice a day, anything you can do to reduce the amount of acid reducing agents they take, you're going to increase their chances for cure. So this is one specific Zepatier. We don't often use it, but if there is indication for use, I kind of put a lot of the things here on one page specific to it. It is the NS5A inhibitor and a protease inhibitor. There are some interactions to worry about. And so I have those listed here. Again, statins are a consideration. The one big thing for them is there aren't any interactions with acid reducers. As Lindsay talked about last week, Zepatier isn't approved in all of the genotypes. And so you would be specifically using this most likely for genotype 1. And if it's genotype 1A, you have to do resistance testing before you can use it. And so that's kind of pricey and delays treatment, but it does have its place and it has its like niche there. So I wanted to put some of that information up. Again, it's not one that I see commonly used here in our clinic. Now, Mavyret is one that we use often. Again, it is a protease inhibitor. So you see the previr protease inhibitor, and then the ASVIR ending. So it's the NS5A inhibitor. It has some drug interactions to worry about, the digoxin, dabigatran being 2. One big one that comes up a lot here, though, is that, ethinyl estradiol containing products. So basically, we're talking about birth control here that has the estradiol component. And so the co-administration of these two increases or potentially increases ALT. And so it's contraindicated. So if a patient needs to be on birth control, you would need to do a progestin-only birth control or a non-hormonal birth control. So that's important. So the ethinyl estradiol is contraindicated. Just a point of clarification, this is not all estrogens. So if a patient is on Premarin, then that's not a contraindication. It's the ethinyl component of this ethinyl estradiol that causes the contraindication. Other things to think about are, again, those inducers we talked about earlier with the other medications. So rifampin, phenytoin, carbamazepine, all the seizure medications besides Keppra, and then the St. John's wort. The statins, again, can increase the dose, increase concentrations and toxicities with that. And then omeprazole. So again, we're coming back to, I feel like the thorn in our side with some of these medications is the proton pump inhibitors. And so the package insert does say there's no dose adjustments required, but 40 milligrams daily of the omeprazole was the highest dose that was studied. So I wouldn't be comfortable going above that with patients. And then they have some weird recommendations on how to take it at the same time, if it's a 20 milligram dose of omeprazole, and then opposite of the Epclusa is 40 milligrams 1 hour before the Mavyret. So anyway, no interactions with antacids or H2 blockers. Okay, so now to move on to a different subset here, hepatitis C and HIV co-infection. About 5 to 10% of patients who have chronic hepatitis C are also co-infected with HIV. And then from the opposite side of that, about 25% of patients with HIV are co-infected with hepatitis C. And this number goes up for patients who inject drugs. So compared to patients that are mono-infected with hepatitis C, patients who have both hepatitis C and HIV are at 3 times the risk for liver-related morbidity and mortality, and that's quite substantial. So you can see here why it's super important that we detect both of these and treat when we have patients who are co-infected. They also have increased risk for non-hepatic organ dysfunction and just overall mortality in general. So this graph kind of here shows you that patients with that are HIV negative with hepatitis C, the progression to cirrhosis is that purple line, so not as high, but patients who are co-infected with HIV and hepatitis C, you can see that over time, their chances are how quickly they proceed to cirrhosis and their chances of becoming cirrhotic are much higher than a patient who does not have HIV. Sorry. When we're talking about hepatitis C treatment here, efficacy and adverse events rates are similar to those observed with hepatitis C monoinfection. And the real thing here is to really think about the drug interactions that could occur between the hepatitis C medications and the HIV medications. This just talks about that the chances that for cure are really high still with patients who are co-infected. And you can see some of the studies here where they look at, these are just all genotype 1 patients, but patients in this column with the HIV Hep C co-infection have still really high 94, 95, 96, 97% rates of cure in comparison with patients who are mono-infected with hepatitis C. And so the treatment rates are great and the cure rates are high, and so it's definitely recommended to treat patients. So what do you do if they have both hepatitis C and HIV? What's the recommendation here? And so the antiretroviral regimens should be chosen carefully, thinking about what hepatitis C medication you're going to put them on at the same time. So basically just thinking about both regimens at the same time, will they work together and how are we going to pursue that? And so it's recommended to start with the HIV treatment first and then to add on the hepatitis C treatment later. So what happens if a patient has HIV and they're already on treatment and then the diagnosis of hepatitis C comes up later? So it's not recommended to stop their HIV treatment, right? There might be some drug regimen switches for the HIV treatment that need to happen so that you can pursue hepatitis C treatment. So that's just something to like come into consideration, but don't stop it, fix it, change it to something else that you can go ahead and treat the hepatitis C at the same time. Here, just like as a review, is Zepatier, the one that I don't see very often, but I just listed some of the HIV medications that can be used with Zepatier and then a few here that cannot. Mavyret, again, I listed here some that can be used, and I'm not going to read them all, but you can see some of the common ones. So tenofovir, emtricitabine, bictegravir, these are ones that you can use with Mavyret. Ones that are not are those ritonavir containing regimens, and then a few others here. And then Epclusa, again, one of the common ones that we see, can be used with almost all the antiretrovirals, right? And there are a few here not to use it with, the efavirenz, etravirine, and the nevirapine. It can increase the levels of the tenofovir disoproxil. And so, you know, we want to avoid this in patients who have a GFR less than 60 anyway, and potentially switch them over to the tenofovir alafenamide if possible. Harvoni, again, has not a lot of drug interactions with HIV medications and can be used with most of them. Again, this tenofovir warning here, so avoid the disoproxil if the patient has a GFR less than 60, and then monitor more closely for renal function if a patient is on cobicistat or ritonavir along with the TDF if you're using Harvoni. So any of these combinations that are expected to increase tenofovir levels, you know, you want to do baseline and ongoing assessment for that nephrotoxicity. This is just a screenshot, and you can go to the hepatitis C guidelines to look here and see like, okay, hepatitis C medications are across the top. You have HIV medications down the left side, and they kind of do a quick visual, which I like charts like this, especially ones that are color coded, because you can quickly see, oh, red, nope. Green, oh yeah, that sounds good. What other considerations might there be? Yellow, then like there's a letter here. So A, you'd come to the right. Okay, A, okay, that's only a caution with tenofovir disoproxil. And so there's a lot of data that you can look at very quickly to see what options you might go with, especially if a patient is already on an HIV regimen. The HIV guidelines also have a similar thing. This is very hard to read on here, so I apologize. I tried to get it to look a little bit easier, but if you go to aidsinfo.nih.gov and look at the guidelines, you can see the same sort of scenario where you can look at the HIV medications along the left side and the hepatitis C medications across the top and see what interactions or considerations you might run into. Okay, so drug interactions, like we talked about, you know, this is not a complete list. Always do a drug interaction check. There are a couple of great ones out there. Lexicomp is one I like to use. There's a hepatitis C drug interaction checker that I love with the hepatitis C medications. There's also an HIV drug interaction checker out there that's from the same company as the hepatitis C drug interaction checker. And if a patient has hepatic impairment, so Child-Pugh B or C, then these protease inhibitor medications are going to be contraindicated. So for hepatitis C, we're talking about Zepatier, Mavyret, and Vosevi. And this is whether they're hepatitis C mono-infected or HIV hepatitis C co-infected. Also, patients who have cirrhosis may require the addition of ribavirin or a treatment extension. Now, right now, I don't think we can get ribavirin. I have not had any luck with that. And so we have been extending treatment for these patients. So like instead of 12 weeks of Epclusa, the patient would be on 24 weeks. Another thing to think about is hepatitis B reactivation, and treating hepatitis C in patients with a history of hepatitis B has been shown to potentially allow for reactivation of hepatitis B. So if a patient does have a history of hepatitis B, you want to monitor for this while they're on hepatitis C treatment and at the end of treatment. And so the way we do that here is monitoring the AST and ALT and see if there's a bump in that. And if so, then we'd grab a hepatitis B viral load to see what's going on there. So very important to watch out for that in this patient population. And then just as a refresher here, the PPI use, right, I really recommend avoiding it in Harvoni, Epclusa, and Vosevi if possible. If not possible, remember 20 milligrams of omeprazole is the max daily studied. If a patient has genotype 1A, then resistance testing would be needed if Zepatier is the preferred medication. Another special treatment consideration is a patient, this is for only for hepatitis C mono-infected patients, but if they're genotype 1, a viral load less than 6 million, not infected with HIV, and non-cirrhotic, they can have a shorter treatment duration of 8 weeks versus 12 weeks of Harvoni. And then clinical pearls here toward the end, always perform a drug interaction check. The hepatitis C treatment outcomes are similar for patients who are co-infected with HIV as they are with patients who are mono-infected with hepatitis C. And it's not recommended to stop HIV treatment in order to start hepatitis C treatment. Remember, you might just need to change the regimen a little bit so that you can pick the most appropriate hepatitis C treatment regimen. I linked you here to the guidelines and for these hepatitis C modules. So if you're interested in learning more about hepatitis C, I love these modules. They're so easy to understand. You get CME for them, and you can do them at your own pace on lots of different ones. And so you can even like skip around, like find things that are interesting to you in that module. But it's from the University of Washington, and there's also, I believe, HIV modules through them as well. I have not personally done this, so I can't speak to them, but I love the hepatitis C ones. And if you have any hepatitis C cases, whether they are mono-infected or co-infected with HIV, definitely you can bring them to us and present them here, and we will help you try to figure out what medications to choose. All right.